Hello, welcome to Mod Midwives, a Metro Midwifery podcast. I'm Gina Gerboth.
And I'm Nedra Hale, and we are home birth midwives serving the Denver metro area.
Well, we haven't done a podcast for a little while, so...
Oh yeah, we didn't do one last weekend.
Yeah, we decided to shut up and let other people's podcasts take the front seat instead of our own. So
yes.
Yeah, there's just too much going on, too much important stuff in the world for us to talk about our normally scheduled stuff. But now we're back to it, and we had something kind of interesting happen this week. I created a social media post with just a quote from a pediatrician. And I don't really, do you really know who this Frank Oskey is?
I don't.
I looked him up. He's an author and a pediatrician. So I don't know much about him beyond that. But anyway, he has this quote, and I'm pulling it up for you. It says that, sorry, my computer's a little sluggish, that $13 to $20 billion a year could be saved in healthcare costs by demedicalizing childbirth, developing midwifery, and encouraging breastfeeding. Oh, I'm sorry. It's Frank Oskey. I think I accidentally said Pete. So, I just made this quote for social media for Saturday Thoughts, and it has completely gone viral. We're over 6,000 views now. I mean, viral for us.
Viral for us. Yes. Please don't make fun of us, people who
are actually viral. We have like an audience of 200 usually, or, our followers, we have like 700 each on Instagram and Facebook, but 200 people might see our things on a typical day or something. Right. This is a big difference.
So it's a much bigger reach than what we're used to. So yay. Yeah. So it must have spoken to people.
Yeah. So I think it kind of hit a nerve. And so I thought that'd be a fun thing to talk about today, or an interesting thing to talk about today. Mm-hmm. So, the potential of midwifery care. What is that? What do you think of when you read that or when you hear that quote?
Well, I mean, I dream of an integrated system, like, something that might be modeled after things they have in other countries where midwives are simply part of the medical system, and low risk people see the midwives when they're pregnant and birthing, and they only see the next level of care if they need to, because they have a medical condition that requires it. So clearly that's what makes sense to most of us, and especially in my brain it does. And so that's exactly where I go.
Yeah, kind of as a first line provider. Midwives as a first line provider. Mm-hmm. So it's interesting. There's a study that came out just a couple of years ago. Let me just pull it up. The year on this study is 2018. So just a couple of years ago, by Saraswati Vidam, who is a CNM in the Pacific Northwest, I believe. Or actually, she might be in British Columbia. She might be in Canada. Anyway, somewhere up in that area.
Somewhere green
and lovely.
Yes.
A couple other researchers that I don't know, Marion McDorman and Eugene DeClercq, who both do a lot of research for the CDC for birth outcomes. Missy Cheney, who is, of course, a midwife researcher that has done a lot of the MANA stats research. And so it's a very, I think, a very interesting group of authors. That it's not just home birth proponents per se. It includes a lot of different types of researchers. So the study is called Mapping Integration of Midwives Across the United States, Impact on Access, Equity, and Outcomes. And basically the conclusions of this study are that in states in the US, which midwifery is not well integrated overall when you compare midwifery to other countries, in states that have higher levels of integration, like Washington State, as an example, which is probably the most well-integrated state. as they talk about in the study, you have better outcomes. So the higher the levels of integration,
right,
the better the outcomes. And this is, I think, really an important thing to think about, because a lot of times opponents of home birth say things like, well, all this home birth research that we have comes from other countries, and that's not relevant to the United States. And there's a little truth to that.
Mm-hmm. Right.
But what's the answer? The answer isn't to just say we shouldn't do home birth. The answer is to fix the system.
Right. Maybe we could do some work on the system.
Right. So improving integration is, kind of an important thing to consider. People will have home births. It's not going to go away. So opponents of home birth are, they're actually creating a problem, because they're creating a environment where they would want it to be pushed underground, which is exactly the opposite of what this study says needs to happen if we want home birth to be a safe choice.
We have to make it easier for midwives to transfer their clients into the hospital system if we need to do that. And it is in many places very difficult.
Mm-hmm. And it's not just transfer, it's also consultation.
Right.
Being able to ask a question. We're really lucky in that we have some friendly docs that don't have, or CNMs in the hospital that don't mind us even just texting and saying, hey, I've got this going on. What do you think?
Right.
But that is not true everywhere. Many community midwives do not have access to those types of resources.
And it shouldn't be that we have to, I do believe in building those relationships. I think that's really important, but it shouldn't be that we have to build those relationships in order to get help. We should be able to just get help.
Right. Absolutely. It should be available and easy.
Yes.
and there should be a procedure in place for here's how to do this. Yeah. Mm-hmm. Yeah. That's a good point. So on one hand, I feel grateful that we have the resources that we do have. And then on the other hand, I see that that's true, that it should be accessible to everybody. So another thing that they talk about in the study is licensure. Part of the confusion and problem is that midwifery is not legal or direct entry midwifery. Nurse midwifery is legal in every state, but direct entry midwifery is not legally recognized in every state. And that creates really a huge variety of state by state differences. Mm-hmm. And I think it's really confusing to the consumer and even to hospitals and other providers.
Right. Yeah. It's just inconsistent. It's confusing. And so much could be done to make it work better.
Yeah. So what would your ideal system look like?
I would love home birth to just be normal and just like a totally viable and common option. But also that having a normal birth in another environment, if that's what the person chooses, is also what is expected. Mm-hmm. So, home birth center or in a low risk hospital setting, and have it just be like a menu of choices. Mm-hmm. These are all normal. And the people who get the higher level interventions are people who actually need them and not everybody.
Mm-hmm. So midwifery care being the first line.
Yeah, midwives in the hospital, mm-hmm. midwives in the birth center, midwives at home, and the OBs are there for the people who need them.
I love the way it works in some Canadian provinces, which is that you book in with your clinic or maternity center. I don't know exactly what they call it, but you get pregnant and then you book in with the center and you get assigned to a midwife or two, or a midwife team maybe. It's probably 2 or 3 or 4 midwives.
Right.
And you go through your care and you do prenatal care, you do education, you just go through your pregnancy. And then as you get closer to your due date, you start deciding where you want to have your baby. So, and it doesn't necessitate a change of provider. So you book in with your midwives, really cool. And then you decide where you want to have your baby.
I would love that.
I feel like that makes so much sense and it might not be true in all Canadian provinces, but of the midwives that I've talked to, that's how it works.
That would be super cool.
Yeah. And then the midwives have privileges in every setting.
Oh, awesome.
So hospital, birth center, and home. Now, all of those choices might not be available in each location. So there might not be a birth center in every location, but usually hospital and home are options.
Yeah. Cool.
The other thing that I think on my wish list is that the consistency of the educational pathway in Canada is really excellent. So there's a lot of, from province to province, it would, easily be recognized, maybe with slight modifications or slight, maybe you have to take a course in something that one didn't have. And the baseline education for midwives in Canada is a bachelor's level education. I think that is the appropriate level of education for a direct entry midwife, and they're direct entry midwives in Canada. They're not nurses. I think that this weird nurse midwife versus direct entry midwife in the United States has created a lot of confusion and division.
Yeah, for sure.
Here, most midwives are nurse midwives, and almost all nurse midwives practice in the hospital setting, the vast majority.
Right.
So it's a very medicalized approach rather than being a midwifery oriented approach.
Right.
And in order to become a nurse midwife, you have to have a bachelor's in nursing, and then you go on to get a master's in midwifery. And I think that bachelor's in nursing is unnecessary. It's not, nursing isn't a prerequisite for midwifery.
Right. Yeah.
So just a bachelor's in midwifery makes a lot of sense to me.
Agreed.
So that would be on my wish list of the Canadian educational process is great. And then they can still manage inductions and epidurals and
that would be so great.
A lot of things like that in the hospital. Yeah. So it doesn't limit the scope. It's very similar to the scope of a CNM in the United States. So I think and the UK is generally similar to the Canadian model, although many are nurses in the UK. More are nurses in the UK than they are in Canada, which is great if you want to be. It's really not a prerequisite.
Right. I think that there's, from what I know about it, it's a really nice system in the UK. And I thought it was really interesting that recently home birth was taken off the menu because of COVID for a little while. And it was such a big deal that home birth was taken off the menu. And whereas in the United States, actually nobody would care, except for this tiny percentage of people that we work with that would care,
It is interesting though, in the UK, they're hugely overworked. They have a huge problem with, so here we can be, scrambling to stay afloat, and they're completely overworked. So they do have a shortage. And whether that, I don't know what the source of that is.
I volunteered to move to the UK. And
me too.
Become a midwife.
Me too. One of my students, she did a year or two at Midwives College of Utah, where I teach, and she did a year or two with me. And she decided she wanted to possibly have the option to practice internationally. So she decided that the UK registration is probably the most reciprocated. So if you have a UK registration, you can kind of work wherever you want. And so she decided to move to England. She's in midwifery school in London now, in Greenwich. I'm so excited for her, a little jealous.
So cool. Yes.
And I'm so impressed at their ability to make that work for their family. Her husband was able to get a job, and she can be there on his visa, and then she can, the hoops that they had to jump through to make that work is,
I can't even imagine. That's so cool.
Luckily he has one of these kind of really specific skills and it's tech oriented, and it's so specific that he can work wherever he wants. He can get a job wherever.
Oh, that's so cool.
Smart people.
Yeah.
Anyway, so I think the educational thing, having a consistent education is an important piece to being able to achieve any level of integration.
Right.
Washington, which is the most integrated state, does have very consistent educational expectations. They have once they take the NARM exam, they also have to take a state exam.
Oh.
And it includes things like epidemiology and pharmacology, and
cool.
It has some extra stuff on top of the NARM requirements. So
that's awesome.
So that's a price that you pay for more integration, is a more consistent education. Yeah. So
but it's a hotly debated topic because of it could be considered a barrier.
It is a barrier. Sure. However, I believe that because I am on the Midwifery Education Accreditation Council. I always forget if it's council or commission.
Council.
I'm on the board. It's council. Okay, good. I don't know why I can't remember that. It's just meek, I will say that I see schools doing a lot of work to reduce barriers, especially for people of color, people of low socioeconomic status, first generation students. So I do think that even though you look at a school and you look at a price tag and you have some sticker shock, I think there's more resources and supports there. Whereas the PEP process potentially has no support and can therefore harder to get through.
Agreed.
So again, trade-offs. It's all about trade-offs, right?
Yeah.
So let's talk about the cost savings. I think it was interesting when this post started getting shared, doula practices and midwife practices started sharing it, that they would sometimes make a little comment about, yes, a home birth is very inexpensive compared to a hospital birth. And yes, that is a piece of the picture, but that's not all of the picture. So where else do you see that $13 to $20 billion of savings happening?
Well, I would say first off, just like unnecessary medical procedures being billed to insurance. A lot of times home birth even bypasses insurance altogether, but even if it didn't, I mean, the amount that's billed to the insurance is like not even comparable to what is billed to the insurance from a hospital birth, even a low intervention hospital birth. So, so that would be where I would go right off the bat, but maybe even more than that, if we could have an integrated system that had more community support, our people might be healthier.
Right. Preventative care saves money. Absolutely. Absolutely. And I think breastfeeding, he mentions breastfeeding specifically. Yes. I think that is an important consideration. The cost of not breastfeeding is much more than the cost of formula or the cost of, supplementary or supplemental feedings. It's the cost of increased medical bills, increased complications, chronic health conditions that are a result of suboptimal breastfeeding. So we're talking about kind of long-term health consequences. So and I think it's easier to see that connection with breastfeeding than with birth, but it's true with birth too. If you have good counseling, good nutrition support, good health, pregnancy is a time for health behavior change. People are usually pretty interested in making positive health behavior changes while they're pregnant. And when you have a midwife who's facilitating that, you're probably going to be more supported and make more lasting health behavior changes. So
it's a great time for people to quit smoking and eat better and exercise. Absolutely.
And those changes can stay with you. It can be like the beginning, not just a temporary period of change. And of course, you mentioned unnecessary medical procedures, but we know this deep in our midwife hearts that getting into the system, the medical system, does lead people down what we call the cascade of interventions. And the cascade of interventions is largely responsible for what is now a nearly 33% cesarean section rate in the United States. Basically, one intervention leads to another, and then we kind of have this big intervention of cesarean birth. So, and I always have to caveat that some cesareans are necessary and life-saving, but not 33%. There's no doubt by any measure that 33% are necessary and life-saving. I mean, that they're not necessary.
That they're not. Just to be clear. Yeah, I mean, I could go off on a whole thing about the fact that there's so many financial incentives to over medicalize everything in the United States. And if we could remove the financial incentives, that would be really impactful on all of these issues. But that gets into a whole different.
I mean, it doesn't get into it. It's completely relevant to this topic because anytime you have a for-profit healthcare system,
yes,
anytime somebody benefits from the over medicalization, then you have an ethical problem.
Right.
It's not ethical.
Big ethical problem.
Yeah. Yeah, that's absolutely right. So,
and let's not forget that the over medicalization has not resulted in better outcomes. We have a terrible record in the United States.
Yes, we have the worst track record of any high income developed country.
Yeah.
Or high income economic. There's a term for these countries. Hang on, I'll look for it. I pulled it up.
Okay.
What we would call high income or developed is called the Organization for Economic Cooperation and Development, OECD countries, which basically is going to be, Europe, the United States, Canada, a number of other countries too, but when you're comparing these countries, we have the worst outcomes. The worst. There are some countries that don't fall in the high income, high development category that have better outcomes than we do. So
it's a mess. It's a terrible mess. I mean,
it's shocking.
I just saw, this is not childbirth related, but I just saw this thing go by about this man who has $1 million hospital bill from having COVID.
Yeah.
And so literally in the United States, we have to choose between going, making our families destitute.
Yeah.
Or dying, like one of those.
Yeah. I mean, and medical debt is such a thing. So many people have medical debt.
Yeah.
And it's not feasible to pay it off, right? How's somebody going to pay off $1 million bill?
They're not. I mean, so it's a broken system.
It's completely,
for sure.
Yeah. We have the worst maternal and neonatal mortality rate of developed countries. So basically we're throwing a bunch of money at a problem. Well, we're not even throwing a bunch of money at the problem to fix it. We're throwing a bunch of money into a system that is causing poor outcomes, because one thing we know is that states that have higher than the average cesarean section rate. So if the average C-section rate is actually 32.8, but I round up to 33%. And actually that's a few years old. It could be a little different now. Approximately a 33% C-section rate. States that have higher than that have higher maternal mortality rates. So it's pretty directly tied to these maternal mortality rates are pretty directly tied to surgical birth, because the complications of surgical birth are, they're serious. They're serious complications. And again, you always are weighing your risks and your benefits. And it's certainly reasonable to think that you're preventing maternal mortality or neonatal or intrapartum mortality with some of these surgeries, but not consistently. When you're doing them in a non-life-saving manner, when you're doing them for convenience or whatever, for however you got to there that wasn't medically indicated, then you're creating risk that didn't exist before.
Right. And then most of the time a C-section leads to another C-section, which leads to additional risks and so on and so forth.
Right. So even if we just look at the topic of C-section, we know that midwives have much, much lower C-section rates than physicians. So in other countries, in these higher economic development countries, 50 to 75 births are midwife percent of births. 50 to 75% of births are midwife attended, regardless of birth location. So we're talking in the United States at about 10% are midwife attended, 10% of births in the United States. Less than 2% of those are community birth or out of hospital birth. So the 8% of births are hospital attended or midwife attended hospital births.
Mm-hmm.
Sorry, there's a lot of words that are just not coming out in the right direction. So certainly we know midwifery care is directly related to a reduced risk of C-section. And so having more midwife attended births would decrease the risk of having a C-section.
Exactly.
Which is an important intervention to try to reduce,
mm-hmm.
unless it's necessary. Good. So let's go back to our wish list, because I think that there is a lot of disagreement I know there's a lot of disagreement in the midwifery community. A lot of midwives believe that integrating means giving up autonomy.
Mm-hmm.
And in countries that are well integrated, they might still be autonomous practitioners. However, there are more checks and balances, but one wonders if that doesn't lead to some of the better outcomes.
Oh, yeah. I mean, there's nothing wrong with checks and balances.
Yeah.
And I don't know how to say this without being offensive, but I don't know that we should be out there making decisions in a vacuum.
Right.
So if that's what autonomy means, I'm not sure that's great. But if it means that we don't have to practice under the supervision of a physician necessarily,
and that's what it should mean.
Yeah.
I mean, that's what it should.
But we have the open option to consult when needed, and we do so, and we are regulated and follow, we consult for things that we need to consult for and all this stuff. Then I think, yay, why not? Why would we not want that?
Yeah. Yeah. The argument is a little bit lost on me too.
Yeah.
But I guess I just want to acknowledge that there's a large group of providers that feels this way.
Mm-hmm. Mm-hmm. True.
So here's what we know. I did this whole program on interprofessional collaboration. Here's what we know, which is basically the academic way of saying integrating into the system. When we're well integrated, we have better outcomes, which right now our outcomes are pretty good. Right now our outcomes are, with certain risk factors controlled for, our outcomes are really on par with what happens. And when I say outcomes, I mean mortality rates or severe complications. Morbidity, yeah. Our outcomes are right on par with other situations. But our outcomes are, other practice settings. Our outcomes are so much better in other ways. Our intervention rates are so much lower, C-section rates are so much lower, breastfeeding rates are so much higher, and client satisfaction is so much higher. So to me, when you have this good integration, we know that we improve outcomes. So that means we're going to get even better. Like the research shows that it improves outcomes. We're already doing pretty well. It would be even better. It would be a no-brainer to make midwifery care the baseline type of provider that you have. And we also know that we save a lot of money, as we've talked about. And we know that the clients are happier. The birthing people are happier with the care that they get when they are, when they're receiving care in a well-integrated system. So to me, you have this trifecta of outcomes, money, and satisfaction.
Right.
And that makes integration a very important goal for me. So
yes.
Yeah. So is there anything else we're missing?
I don't know. I was just going to go off on a tangent.
Go on it.
Improved breastfeeding.
Yeah.
Improved physiologic beginning of life, skin to skin, all of these things. Lower incidence of large perineal tears.
Yeah.
There's just so much about midwifery care that's really important for the health of the person forever and ever. So we need more midwives.
Yeah.
Especially in the hospital, maybe.
Yeah. That was actually a question that came up on the Instagram thread was, wait, do we have enough midwives? Because I'm saying there's no reason we can't be, following suit of other countries. And they're like, do we have enough midwives? No, we don't have enough midwives to do it right now. Even we barely had enough to deal with COVID.
Right.
So, we do need more midwives, but it has to start with consumer demand. Oh, I wanted to circle back to something you said, which had to do with insurance companies. I can't remember what you said. You used the word that triggered me to think about it, but now I can't remember what it was. One barrier to integration is lack of coverage, because unfortunately, insurance coverage is how we do it in the United States. Not being covered by insurance companies is a barrier to improving or increasing the rate of midwifery care. So if you're listening to this and you're a consumer, this is how changes start. Consumers have to demand change. And so, requesting insurance reimbursement is a big piece of that.
Maybe it was about bypassing. The home birth bypasses the insurance system a lot of the time. And the reason for that is not because we want it to be that way, but because they don't cover us. We're not in network with, we're not in network with anybody, and that's pretty common for home birth providers.
And as long as we're bypassing the system, there will be problems with integration. Yeah. That's absolutely right.
Yeah, so there needs to be some reform about how that is.
But being in network has its own set of challenges too. The reimbursement rates are terrible, and we can't make up for it in volume the way that they can in large practices. So there are definitely some challenges there. But again, I'm going to go back to the very first thing I said. Working on these challenges is the answer. The answer is not abandoning home birth.
Right.
Because it's
Why
going
don't we
to happen.
Identify the problems and see what we need to do about it.
Exactly. Exactly. We can improve this system in the United States. And the maternity system is broken. We can be part of the solution. So I feel really strongly about that. I hope that people start demanding change. I actually see it happening. I see that we're reimbursed at a higher rate now, or higher frequency than we used to be.
Yes, agreed.
So I see it happening. Change is slow. But once we get people really demanding this kind of excellent care that we can provide, I think that we'll see more.
Consumers.
Yeah. Thanks. Thank you for finishing my thought. We'll see more something. All right. Can you think of anything else that you wanted to say about this?
It's so big.
It's big.
Could go on forever.
And it's doable. It's big and it's doable. And Rome wasn't built in a day, but we've got time.
We do as a human race, as long as
a collective.
As long as we're not destroyed.
And destroying ourselves. And
yes.
That's a good point. Anyway, so that's about that. That's about it for that topic. If anybody has anything that they'd like to add in the comments of social media, we would love to hear it, because I think it's actually really big. It's actually a really big thing, and it's really important for choice to have. It's important to become integrated in order to have more choice, and that's what people want. There is that Listening to Mother survey from the Childbirth Collective. That's not what it's called. Childbirth Connection. And people want choices. They want to pick their providers. They want to pick their birth settings. They want informed consent. They want shared decision making. They do not want to be told what to do. So it's time to break out of that patriarchal system.
Yes.
All right.
Yes. Let's do it.
All right. So follow us on social. Oh, guess what? We do not quite have 800 followers on Instagram yet, but we picked up a bunch this week.
Yay.
And I was thinking we should do some kind of giveaway for 1,000 followers. So be following us on Facebook, because we will have some kind of surprise. I don't know what it's going to be, but we'll come up with something. So follow us on Facebook, and Instagram and Twitter. Actually, Nedra shares so many good articles. Like really the truly
There's good stuff on Twitter, you guys.
The truly meaty, deep stuff is on Twitter. The pretty stuff is on Instagram.
Yes.
And I do a fair amount of sharing on Facebook, like forwarding articles. But the really good stuff is on Twitter. don't skip on the Twitter, people.
Yes.
All right. We'll see you. Take care and have a good week.
Bye.
Bye.